right, today in the LeaderSeat podcast, we have Dr. Joe Kvedar, a trailblazer in digital health and telemedicine. He's a senior advisor of Center for Innovation in Digital Healthcare at Massachusetts General Hospital, professor at Harvard Medical School, editor-in-chief at NPJ Digital Medicine. He was the immediate past board chair at American Telemedicine Association. He is the author of two books, The New Mobile Age, How Technology Will Extend the Health Span and Optimize the Lifespan, along with The Internet of Healthy Things. Dr. Kavidar's experience has transformed healthcare through technology, and he brings a wealth of expertise to our conversation today. And I'm glad to have you on. Thank you so much for joining me.
Oh, I'm delighted to be with you. Looking forward to the discussion.
Of course. So I want to jump right into it. I was on your website and I saw the headline under your name states Reinventing Healthcare. At what point of your journey did you want to make that change to reinvent healthcare?
Well, that goes back to the early 1990s. So I finished my residency in dermatology at the Harvard Medical School program in 1988. And I was, like many people at that time and in that organization, drawn to the laboratory. I was a laboratory investigator with a little bit of clinical responsibility for a few years. And during that time, I was the time that the first wave of managed care was moving in. There was a lot of talk about capitation and new payment models, and I just felt like my colleagues weren't really responding well to that. My professional colleagues writ large in medicine, and so I was just always looking for different ideas about how to deliver healthcare in different ways, and I stumbled literally into this world of telehealth. I was doing a project on a new technology, new at the time, called digital imaging as a diagnostic tool in dermatology. And it really hit me one day, one of those aha moments when I said, if we could separate the medical knowledge part from where the patient is, we could just do all kinds of interesting things. And I sort of never looked back. So that's how I got started on this in this crazy world. I'm an accidental tourist.
You mentioned your colleagues didn't pick up the technology or the new way of doing things much. Do you think that's common in medicine or healthcare? Because when we go to school, we're just so focused on studying. We got to pass the boards, we got to pass the exams, we got to take to the next step, and we're not really shown that side of things, like technology, innovation, entrepreneurship side of things.
That's getting better. When I was coming up through the system as a junior faculty member, I remember turning away students who wanted to work with me, saying, "I don't think you'll get a good residency spot if you come and work with me." So that was how it was then. We now have, of course, MD, MBAs. We have most of the young people in our training programs have one foot in some sort of startup now. So it's getting much better. But the core of what you're saying, I think, is still a problem or a scenario, which is that it's two things. One is it's a very hierarchical system, and if the people senior to you encourage you to think a certain way, you probably do. I guess it's three things. The second one is that that people are risk averse in healthcare typically, and the third, I think, probably the most important one, is that we are always worried that we're going to do some harm to a patient. So we stay within a very narrow lane of risk taking with regards to patient care. And telehealth or digital medicine, as it's evolved, really was about a new way of delivering care in the beginning, and people were kind of spooked by that. And I still have discussions it seems like at least once a week about, well, is it in person better? And what about, you won't be able to do the palpation or this and that. So we're still going through it, I think.
Yeah. So the terminology connected health, that's something that's fairly new, that obviously you're very much familiar with. Can you speak on the difference between connected health and telehealth? Is there a difference?
Well, it's if I may tell a little bit of an
Of
interesting
course.
story. In the mid 1990s, the organization that I was overseeing was called Partners, was our corporate name at the time, Partners Healthcare in Boston. So the organization that I was overseeing was called Partners Telemedicine. That's what we called ourselves. But we were into certainly much more than video calls with patients. We did a lot of asynchronous work. We were doing early work with texting and chatbots. We were doing remote patient monitoring with, that was one of our big focuses, was monitoring patients with, for instance, congestive heart failure in the home. So
This is
we
what
were
year?
thinking, about 1990, 2005, my mistake. So I was invited to talk to the board of directors of our company about the work we were doing. And at the time we were working with a professor at BU. He was more in marketing, and he had this concept called connected home. And we were kind of warming to that. So that was in the back of my mind. And the chairman of our board, after I presented, he said, "This is fabulous work, but you do yourself a disservice by calling yourself telemedicine." And so it was really one of those leadership moments where I went back to the team and I said, "I think we're going to change our name." Now, of course, it's interesting because now in 2023, telemedicine isn't such a foreign concept anymore, but it is limiting in a way. And connected health at the time, just, it gave us something new to talk about. It was really that simple.
Yeah.
Now, I want to hasten to add that our field has this problem where we try to rename things every 3 or 4 years. We go to M health, E health, mobile health, connected health, digital medicine. You know, everything is a medicine and a health. It's really maybe not the best thing for us. I think somebody does that usually because they see it as their path to fame and innovation, that they created a moniker that they want to steer. The virtual is another one, right? Virtual care, virtual everything. So of course, we want to end up in the place where it's just medical care and health, and we happen to use some of these other tools. We're probably not there yet, I would say. But anyway, that's how connected health got started. It's a term that sort of came and went, to be candid. I think now mostly people will say digital health, digital medicine, and yet, as I alluded to, telemedicine's had a bit of a renaissance as well in the last 3 or 4 years.
It's funny you mentioned name changes that happen all the time. I think that's kind of negatively impacting our patients, because I feel like health, it's something where patients won't take so seriously until they're comfortable with it. Like as far as like the care they get from who they get it from. And I think it takes a while for someone to get comfortable with them putting trust in someone else to take care of their health. And these name changes are kind of making us move backward, because then we're going to have to try to convince the patient that this is okay, this is going to be better. How we go about, and that universal healthcare thing, like that EHRs, there's so many different places. A person can go to a cardiologist and they can go to their internal medicine doctor, and the cardiologist has no idea what the internal medicine doctor did. Do you think that this connected health telemedicine, we'll just go with connected health so we don't confuse. We're going to pick that word and go with it.
Okay.
Do you think that that connected health model can be the start of the hub for a patient's care, where there's not going to be so much confusion in different types of specialties going different places and et cetera?
Yeah. Well, it's a wonderful vision that we would have sort of universal interoperability, right? I completely endorse that. I fear that that's unlikely to happen because of the way business models, at least in the US, are, that nobody has good business benefit from being interoperable. So
Can you elaborate on that?
well, data, of course, the tired adage now, data is the new oil. Whatever you want to say that sounds cute, data is really valuable.
Yeah.
And if I take care of a cohort of patients, one of the reasons they keep coming back to me is that I have their records. And if those records are freely available to my competitor, they may go there, and so it's a little bit of barrier to entry thinking there. I think on the medical record, the EMR company side, that's easy because again, if you ask Judy Faulkner from Epic, she would say, "Oh, I know how to solve that problem. Everyone should just go on Epic. That's easy,
Yeah.
right?" So everyone has their own way of thinking that interoperability is not necessarily good for their business. Health plans, same thing. So whereas in countries like they seem to have done a pretty good job in the UK as far as I can tell, and with an NHS and so forth. But so I hate to be, as they say, a skunk at the picnic on that topic, but it's the right thing to do. But so far, we haven't found a good business reason for people to do it. But yes, to answer the question after that long-winded digression, yes, that would be great. That connected health would mean exactly what you said, that it's there's this sort of central information which is about the patient that follows them around, and that you can access it as needed for helping care for them.
So let's talk about Facebook, Google, Twitter, Elon Musk, Amazon. So Amazon's already touched into healthcare a little bit with the pharmacy realm of things, and they're
Mhm.
going in. Do you think that Facebook, Google, X, that's now called X, stepping into healthcare can try push this connected healthcare model?
Well, of the ones you mentioned, Amazon, I think, has the best chance. It is interesting that for 2 or 3 years, they've been swinging, as it were, use a baseball analogy, and swinging and missing. I don't fully understand why. I kind of want them to succeed because they're so darn good at customer service, and we in healthcare are not. So I think if they were to be a credible threat, that would cause all of us in the delivery side to up our game a little bit and treat our patients more like customers than some of the way we treat them now. I'll just leave it at that. So I would like to see that successful. I thought when they acquired One Medical, that was going to do it because they could have this kind of virtual first, but whole package of services. Didn't seem to happen. I don't know a lot about, I'm not a business person, but I think it's fascinating to see how well it seems that Whole Foods worked for them. But One Medical is, I don't know why it's stumbling. I'm not sure. The others you mentioned, the social networks, maybe there's a sort of, a sort of side gig that it's hard for me to see Twitter, X, whatever you want to call it today, getting into the healthcare space and in the delivery side. I mean, there might be, yeah, it's hard for me to imagine that. Facebook has a little bit broader remit, I think, but again, I don't see them doing delivery per se. They might, yeah. I mean, I think of all those, Amazon, as I see it, has the best chance.
So I
And
think
right
you
now they're stumbling. Yeah.
I think you kind of answered this question, but I'm going to rephrase it in a different way. If you were to put your money on it, Jeff Bezos, Elon Musk, Mark Zuckerberg, who would it be?
Well, I'd like to see the cage match. No, I'm just kidding. It would be Bezos. Yeah.
Bezos. Okay. All right. And even though Elon's getting to the, the Neuralink and stuff like that, you don't think he's gonna be it?
Well, maybe again, I think, broadly speaking, when people say they're going to be in healthcare, does that mean they're going to create devices that does the
Yeah.
therapeutics, delivery, right? I think my bias, because I'm a practitioner, is I think more about delivery.
Hmm.
Um, so Neuralink, fair question. That's not Twitter. So we were talking earlier about Twitter and Facebook. So yeah, maybe. I don't know.
Yeah.
Maybe any of them through their foundations or their side interests. The guys at Google, of course, have
Yeah.
Verily and all kinds of things going on to try to cure the world's diseases. So broadly speaking, maybe, but the core business of Twitter to me doesn't speak to
Yeah.
a healthcare push.
You mentioned earlier, we're not good at customer service. Isn't that what healthcare providers should be good at? Since we're, our customers are our patients. Why did you think that, and what made you say that we're not?
So it's a two-part question. I think one is the first part, should we, and the second part is why aren't we? So let me try to break it down, give you my perspective. The answer should be is yes. So there's so much I think really interesting research and literature on how a patient who is bonded with their provider has better outcomes. And it may sound a bit corny, especially if you're in the more sort of surgical side of things, where you think your physical prowess with a scalpel and a needle holder is what makes a difference. And of course, that's important. But yeah, there's a lot of research that patients who feel that trust, they feel that bond, they feel like the provider really cares about them, will do better. I think the reason that it doesn't line up that way is fairly simple, maybe, and that is that we don't really, I mean, patients aren't customers. They aren't. The customers for us are probably the health plans. They pay us to do stuff.
Yeah.
And that just creates this sort of twisted sort of three-way relationship where to be crude and crass, I can run patients through a mill. The more I run through, the more revenue I generate. The more revenue I generate, the more I take home, right? So, and of course, we all know practices like that, whether it be in practice like ophthalmology or some of the surgical specialties, where one of my former professors, when I was just a medical student, had this term, which at the time I was upset by, but I've used it, and that's treating patients like biological cash registers. So we can do that if we choose, and the system will reward us financially for doing it. So I think we talk about efficiency. We do all these things to run our offices more efficiently from a process standpoint, but we don't really get compensated for treating patients well, meaning psychologically treating them well. It's just it's a sort of a sad fact. It's a little bit like on the telehealth side, we always talk about one of the, and I've been spewing this for the last couple of years, since the pandemic, which is telehealth's the right thing to do. Check that box. But just because a patient doesn't have to drive 2 hours to see you, nobody ends up but the patient benefiting from that. And there's no financial, nobody's cash register rings when a patient doesn't have to travel. Anyway.
Do you think that the fact of what you just said, like that, the fact that the patient doesn't have to travel and the physicians are doing things telemedically, if that's even a word, do you think
just
that,
made it one.
yeah, do you think that can make the physicians or the healthcare providers lazy also? Because they're like, oh, I could just get on this call real quick and get this out of the way and get this patient out. It's kind of like a get them out of the office a little faster type of thing.
Yeah. There is a danger there. I don't think we're far enough down the road of what we typically refer to as hybrid care models, which are some things in the office, some things. We're not quite there yet to make that happen, but it bleeds into a couple things. So one of them is this informality of being on the internet, and that certain practititioners and patients, but of course the patient's the one who needs the care. So certain practitioners will be a little more informal, perhaps over a medium like we're talking on now. Example, friend of mine had a virtual visit some time ago. The doctor picked up the call, was on the beach in swim trunks and no shirt.
No way.
So I said, gosh, I bet that individual wouldn't come to the office dressed that way, right? So there's something about the spontaneity and that sometimes throws people into that mode of not taking it as seriously.
Yeah.
And it's debatable whether, particularly video calls. So there's we've said lots of different virtual care models, but particularly video calls, it's debatable if they're more efficient or not. And if you can move the patient along quicker. But I can definitely see some people maybe thinking that way. There are, of course, in the US now, I don't know how many, maybe let's say a dozen, there's probably more companies that do these little quickie visits for things like filling your birth control or erectile dysfunction or what have you. And those are all pretty quick. That's because they're being efficient from a business perspective. And I think if you take the use case of something like that, where the patient is, I just need my X refilled. Why do I have to drive, park, wait, see you for 5 minutes? You nod at me and you say, yeah, it looks like you need a refill. Why can't I do that online? So there's a narrow slice where we might all agree that that quickness is of value. But yeah, I think there's a danger that we misuse it. Absolutely.
So the terminology telemedicine has been around. It's not a new concept. It's been around for years, even before COVID, way before COVID.
Way
Do you
before, yeah.
think that the telemedicine community took full advantage of COVID to try and implement this style of healthcare? It's kind of like, this is our time, this is our shine. Like we've been, everyone's been doubting it, but this is our time to show the benefits or the value. Just like I'm a pharmacist, and we kind of brought that along with the vaccines. Like this is our time to shine and show our value that we could bring into the healthcare field. Did you guys feel that on your end?
Yes, yes. So let me parse out a couple of things on the answer. One is telemedicine is not a new term. On the other hand, having been in the space now for 3 decades, there was a dramatic change during the pandemic in the sense that both providers and patients, everyone now knows what the term means.
Yeah.
So I used to talk to patients about, and I would end up having to explain what it meant. Never now. Do you want to do your follow-ups virtual? Do you want to do them in person? We have that discussion. Everyone knows what we're talking about. So there's something there that I think is important to note. The real answer to the question is pretty interesting. The answer I think is yes, with a bit of an asterisk. We did rise to the occasion. We worked pretty hard for instance, to do a lot of policy work to keep some of the reimbursement pathways open, to help as we could with state licensure and other things. At the end of the day, if I may use that phrase, where we are now, it is still financially a better outcome for a hospital system to bring you in the office. Okay. One hospital system near me, and I just because I know one of the doctors there, sent a memo to all their doctors saying, we're not going to do telehealth anymore because we can't charge a facility fee. So for your listeners, that might be a bit arcane, but if I go to a hospital to get my care, outpatient care, a clinic, but it's run out of the hospital has something called a facility fee that they will bill the carrier, the insurance carrier, on top of the professional fee of the doctor. And for telehealth, of course, that goes away. So there are little sort of twisted things like that I think have kept it so that, well, right now, just to sort of be very concrete for a minute, about 5.5% of healthcare claims that are generated in the country are for telehealth visits, and that's been stable since about early 2022. So a year and a half. Of those 5.5%, 68% are behavioral health. And we haven't talked about that. We might, but that's really been the one field that's sort of broken out over all others in the space.
I've actually, when I was doing my rotations in the hospital a while ago, that's the category that telemedicine was used mostly in, actually. So it's funny you said that. How can we maintain this momentum of connected health adoption post-pandemic?
Well, we're more or less post-pandemic now.
Yeah.
I think it's a great question. I look at my own practice because I just think there's something there to be thought of. Now, just to digress for a minute, I'm a dermatologist. Many things we do for our patients require little procedures like freezing something with liquid nitrogen or a little biopsy or this and that, right? So one of the things we learned over the pandemic is that there's a small slice of what we do that's quite good for telehealth, but it's a small slice. With that said, one of the things that we can do well with telehealth is follow-ups for patients who are on acne. Sometimes patients that have psoriasis and eczema can be followed because they're getting better and they're not changing. They can send images over the portal. We can evaluate them and then have a phone call or video call. So that's been our version of hybrid. And the reason I digress on that is because I find myself in the last 4 or 5 months not paying as much attention to offering those virtual options to the patients that are in the office. And I do, but during the latter part of 2020, the first part of 2021, that was all we were thinking about, you know.
Mm-hmm.
Now, on the flip side, the positive side, we just saw the Medicare fee schedule. There's a lot of positive change continuing to happen for providers to get paid to do telehealth. Medicare is being very supportive of that, so we should give them a shout out. Private payers, plus minus, which is another thing that makes it challenging if whoever does your revenue cycle, whether it's a hospital or a practice, has to be having a brain cramp over who to bill for what. That's a problem. But that's a key one. Billing is a key one. You already talked about one key one, which is electronic records. So we're there. Yeah. That was a coincidence, but the fact that we have electronic records makes us much more doable. And by the way, almost all of them now have integrated video capability. Yep. Right. So there's a lot of positives there. But I think one of the things that we as an industry, and you mentioned my role at ATA, I still do some work with ATA. And one of the things we're sort of grappling with is, I mentioned 5.5%. What's the right number? What's the right amount of telehealth? We haven't sort of put a stake in the ground and said we should be doing 20%. We should be doing because we haven't generated necessarily the data to support those claims. My gut sense is that we're underperforming right now. Again, except for behavioral health. God bless them, they're doing great. But I don't know how much we're underperforming by. And I'll say one more thing. I don't mean to ramble, but in my own case, prior to the pandemic, we used to celebrate dermatology as a great field for telehealth because it is so visual, but we never put two and two together to realize we do so many things that require us to be in contact with a patient that we learn that. So I don't know. I know endocrinology, lots of opportunity there. Neurology, lots of opportunity there. Primary care, it's a lot of, maybe we'll talk about this as well. Virtual first primary care is a thing now. So there's lots going on. And I would say that the pandemic spurred a lot of that. Once again, patients now aren't afraid of it. They know what it is. Most of them have had good experiences. So, but I still think we're underperforming. And on the delivery side of the house, which is the hospital systems, doctor groups, practices, we still have pretty significant financial incentives to bring people into the brick and mortar.
Yeah, when I was reading up on you and your background, and I saw you were a dermatologist, I was going to ask you that question of like, it's interesting how you're so into the digital health and connected health, and coming from a dermatologist, I was like, dermatologists, I feel like they're very much hands-on with their patients, and you want to answer that, so that was interesting. What initially sparked your interest in using technology to transform healthcare delivery? Or were your parents, is this something like, were you raised as a kid? Were you a technical guy? Was your dad into the family? Where did that spark come through?
It's a good question. The answer on the family side is both of my parents were high school educated, simple, plain, really good folks, right? Very, very sort of solid people. But I think my father, he lived till he was 88. I think he got his first credit card when he was 82. So hardly a technology geek. I always enjoyed. I grew up kind of watching computers go from rooms that are huge when I was in high school to something you could put on a desk, to a laptop, to a mobile smartphone, etc. And I was always a fan of what technology could do to help me be more efficient in my work/home life. So a little bit interested in the new app when that was a thing, or the new phone, or the new smartphone, or going from a desk phone to a mobile phone to a smart, all that stuff was stuff that I was on top of. Wearables, right? I used to have 3 or 4 different wearables on at any given time, checking them out. So there's that. And I alluded to this before, just so quickly to tell it again, that the thing that tied it all together for me was exploring this notion of digital imaging in dermatology. and how that would allow us to have a patient be, well, nowadays in their own home. At the time, we didn't even envision that because it was digital camera was 1 megapixel, $12,000, the size of a shoebox, right? So we thought they would be in primary care offices and that primary care docs could get a dermatologic opinion that way. And that like I said earlier, I thought we're so underperforming. Even in the mid 90s, it was clear that industries were going in this direction of doing things virtually. And now, of course, I always make the comment, usually when I'm out on the stump, there isn't a service, maybe other than getting your hair cut, there isn't a service you consume that you can't do right on your mobile phone first. And yet healthcare still has this, yep, call in, yep, we'll see you Thursday afternoon at 2, because that's when we have a slot in the schedule. We don't even do open table well. So it was really that thinking, God, we could do so much better. We're underperforming and technology could help us. Now, again, over the years, a few curveballs have been thrown in, and we're at this point now where people really pushed at least the virtual video part, and they're sort of recoiling a little bit saying, yeah, I'm not so sure that that's good for everything. Now, I will say I never thought it was good for everything, but I might have been a little more of an evangelist before the pandemic. So it's been fun to see it in real time and then sort of say, well, like I said, maybe it's 20% of our activity, not sure, but it's not 100% for sure.
You've mentioned it, I think, multiple times now, underperformance.
Yeah.
What is it who we are as healthcare providers that it's causing us to underperform? Is it the surroundings? Is it the services? Is it the support? Is it what is causing us to underperform? Because people like yourself obviously see the vision. Are we not
Yeah.
pushing it enough to the up and coming healthcare providers to see that vision? What is it causing the underperformance? Because if we show the value, it should just come.
Yes. Well, and so you're going exactly where I was going to go with my answer, which is to again be redundant to something I've said a couple of times. The business models don't necessarily support it. In what I would envision. So people ask me what would it look like if it was really successful or perfect or what have you, and that is you have a need to interact with your healthcare provider. Again, you go to your mobile phone first. That's rule one. You enter some information, and then we say, "Oh, we can help you." Now, once again, I'm not making this up because this is how tech support is done in every part of the industry now. There's a robot on the front end, right? We didn't talk yet about GPT and that stuff, but so there's a conversational agent that sort of says, "Oh, you know, did you reboot your computer, et cetera." So you'll get something like that, and then if you really do need a person, based on whatever you input, you'll get shunted to virtual or urgent care. And if it's urgent care, there are 5 nearby, and this one has only a 10-minute wait, 6 miles. Just again, we've seen all these technologies and restaurants and Yelp, and yet they're not there in healthcare yet. Or you better go to the emergency room, or it's okay. You can wait and see your primary care doctor, again, virtually or in person, depending on the scenario, in 2 weeks. And some of this is happening. Well, interestingly enough, the stuff that's happening, we'll collect your copay ahead of time. We figured that out, right? We somehow we stumbled through that one. So, but having it all integrated, having the maps integrated, having the wayfinding integrated, having the seamless transition between something that's virtual and something that's in person. When it's needed, you get in person only when it's needed, etc. That's what it should look like. And I think what's holding it up most, once again, is business models. That story I told about facility fees, I maybe it was obvious when I told it. It bothers me a lot that we have that sort of, you know, that it's a truism that any business becomes dependent on certain revenue streams, especially the easy one. facility fees are a relatively easy revenue stream. So let's take those away. No, wait, I got to pay my rent. I've got this big, I'm building a new building, right? How many health systems are building new buildings now? All of them. So it's, we just haven't made that leap. And I think the other thing that you asked about this, yes, training practitioners, but most of our, almost not most, all of our practitioners that are coming out of medical school and residency now are what we call digital natives, right? They grew up on mobile devices. If they had to break up with a boyfriend or girlfriend, they send them a text message. They get this. That's not the issue. It's that we've put them in these cages around how we ask them to think about care and how we pay them and how the organization gets paid and how they organize their time and etc. So I think it's less, and finally, the patients, not all, but many of the patients, if you choose your use cases well, patients love this stuff. I have at least one per week. I do my sessions, I should mention, on Tuesday afternoons. At least one per week will say to me, wow, this was great. I didn't have to drive to see you. We got all this stuff done in 10 minutes. Thank you so much. People love that. But of course, what they don't love is if you don't treat them seriously and if they really should have come in, so they end up wasting their copay and time. And you say, you know what? Sorry, this shouldn't have been in this way. Come in and we're going to bill anyway, but come in. We've got to get that part straightened out.
I think what you said is it's right on point. I think all it takes is a one person healthcare provider to mess it up for everyone, and it takes that one healthcare provider to make it great for everyone, especially because it's such a new thing. So I think the ATA, like the training, maybe like if you're trying to provide that service, ATA needs to do some like training courses or certification in order for you to be able to even give that service, because again, like it takes one person to make it great and one person to make it really bad. You mentioned the facility fees also. It's funny. Do you feel like healthcare providers are always fighting for the better of the patients? Like, why do we have to fight so much to get certain laws passed that are like so obvious, maybe, or even like on the pharmacist end, we're fighting right now for provider status. Like, pharmacists provide a lot of great value to society, whatever, and whatever it is. And AMA is just so against like pharmacists becoming provider status or being able to that. Why is there such a fight in the healthcare world, and why can't we just understand the values of everyone and understand that we can provide this value, you could provide that value, this is better for that, and we just move forward? I know it's a very hard question to answer because obviously there's more into it than that. But why do you think we always are in this battle of fighting and going to the Capitol and trying to get these laws passed and spending our quality time we could be spending with our patients in the Capitol trying to pass these laws?
Yeah. Well, one quick point. I do work with the AMA, so I don't want to, and I don't speak for them at all. So I don't want to just to make that clear that I'm speaking as myself. But I think the answer, it's a little ironic. So rather than talk about non-MD clinicians, because there's a lot of different,
Correct.
PAs, NPs, pharmacists,
Correct,
midwives, etc. Even within my own professional sphere, people, as I said earlier, when we were talking about data, people are very kind of, they spend a lot of time worrying that their patients are going to somehow go to someone else. And it's a zero-sum game, divide the pie mentality. And there are other industries and other fields where the successful businesses are about enlarging the pie, not dividing the pie. But in healthcare, it doesn't seem people get there for some reason. And I guess the reason I say is there's an irony there. The irony is that we all have, as I think I said this earlier too, we all have a 6-month wait. Waiting rooms are full. We can't seem to get everything done. And yet, God forbid that my patient goes to another doctor down the road, then I'm somehow losing something. So, and that extends to the MPs. It extends from ophthalmologists to optometrists. There's always someone will bring in quality, and I don't mean to imply that the quality side of this is simple. It has to be solved, and you're right, everyone should practice at the top of their license. Pharmacists are incredibly valuable partners. but to the top of the license and no more. And so it's something that the financial part of it gets in the way of solving it.
It's funny how it's always going to go back to business and money. Money runs the world. It really is. It's
Yeah.
really unfortunately true.
Unfortunately, it does. Yeah.
Yeah. Um, this quote I'm sure you're familiar with. The future is already here. It's just not evenly distributed.
Yes.
William Gibson. What
Yes.
what
I
part of that is what part of where we're at right now is not evenly distributed?
Well, so I'll use one example. There are many. I mean, there's the Aura ring, which is a ring that can take with a little bit of tweaking, will be able to take your blood pressure. That the ring is here, but that fine tweak isn't, right? So and there's all kinds of in the engineering world, there's all kinds of examples like that. Most of the things that we think of as mainstream engineering achievements have a 20 or 30 year period where we didn't know about them. They were out there in small bits in the marketplace, failing because someone tweaked some design element or something. But I think in the one example I would give that's nearer to home right now is this idea of virtual first primary care, and I alluded to it. The idea that you, as a consumer, usually through your employer, can sign up for a plan during open enrollment where you get a pretty good premium cost, better than other plans. So it's a discounted premium. And yet when you need to interact with the healthcare system, it's going to be initially a virtual interaction. And then if you need to see someone, you see someone. That is it's happening, and it's not evenly distributed, right? In some places that's quite popular, but those, Amazon, that's what Amazon is up to. Optum and United Group are doing it. Aetna's got a program. Even Walmart is wading into those waters. So that's, I think, an example of an innovation that's just early on the curve. So if you're that kind of person who saw the opportunity, took it, and are using it, then it's in your life. But for a lot of people, they'll be looking at that saying, "What? I don't know what that is. I never saw it before." So that's an example.
Which countries, from your experience, are the leading in the connected health providing of healthcare? And uh, narrowing it down from countries to which states do you think are doing the best job at that?
I'm not in the U.S. I don't think of it by state. So,
Okay.
but I will say California, because their legal structure, I'm sorry, their reimbursement legal slash structure has been promotional, not just of telehealth, but of value-based reimbursements and managed care and so forth. Minnesota, Massachusetts does pretty well. There's sort of middle of the pack, I would say. In terms of countries, I think Germany's really interesting. I don't live in those other countries, so I don't dare say they're doing better than us. But I think Germany's interesting. They have a really interesting regulatory environment for mobile apps and digital therapeutics that I think we should all be looking at carefully. UK I mentioned because the NHS is one system, so there's a lot they can do. And Denmark has enormously good electronic health records and genetic records, so they're doing some really interesting things in Denmark by combining those data sets and preventative care for people.
When I mentioned earlier in the intro that you're a professor at Harvard Medical School, do you have this implemented into your lectures, the digital health, to kind of speak to the students and um, guide them a little bit, I guess?
Yeah, so yes is the quick answer, but let me elaborate a little bit. Because I don't want to mislead any of our viewers or listeners. The term faculty at, I think, most places, but certainly at Harvard is a broad-based term. So you could be a successful professor at Harvard and not do any teaching. They value people who bring in a lot of research dollars and do a lot of research. So you can be a professor broadly. I do some teaching, and it's in the context of the journal that you mentioned that I'm editor-in-chief at. I have Harvard medical students who work with me on the editorial process. So understanding which papers are notable enough to write editorials, and then helping me write them. So it's a direct link because the journal's a digital medicine journal. Mm-hmm. And then of course I teach residents in the clinic. They're not medical students, they're beyond that. They're training to be dermatologists. And of course, yeah, we constantly talk about this in the clinic.
What are some innovative projects or partnerships your team has been involved in that you would like to put a put a spotlight on?
Well, so my team it's an interesting time in my life. I don't have the center that I used to run. We disbanded that several years ago for a few reasons. So I'm now kind of my own team. But working with ATA on some of the research questions I mentioned earlier about what's the right amount of telehealth. That's one I'm pretty excited about. Working with the journal to get the word out. It's the journal is doing well in the scientific community. I'd like to get it so that we're viewed as reading material for people that aren't hardcore scientists, that are either executives in the space or practitioners or what have you. So I'm working on that vision as well. And then I mentioned I work with the AMA. We're really heavily involved in reimbursement strategies. That stuff is so impactful because if we could we were just looking, for instance, the other day at the billing from CMS, Medicare on the remote patient monitoring codes. We put those in place, and I believe they went in 2019, and so much more remote patient monitoring, which is a good thing for our patients. So those are some examples of things that I'm working on that are exciting to me.
When I was a student going through rotations, we did a pretty good amount of actually telehealth visitations with for ambulatory care areas, for especially with diabetes education, stuff like that. Equal access is something that I think is a big part of trying to make this equal access. Might be a problem. Some people live in a less fortunate situations. They don't have computers, Wi-Fi, so on so forth. How are you, I guess, envisioning this moving forward, where we can provide that equal access for everyone in the telemedicine side?
Well, you only ask easy questions. So that's the hardest one. I mean, it would be flip of me to say, well, universal broadband, which is an answer to that question. And there's of course been some effort by the Biden administration to increase broadband penetration, particularly in underserved areas. But as you say, there's there's uneven device distribution, and other things too, right? We don't want to kid ourselves to say if you gave everyone a device and good internet connection, that somehow would solve healthcare access. But so there's health literacy challenges. So what we think about is in the telehealth space, we don't want to be cast as a part of the problem. We want to be cast as part of the solution, but we aren't the whole solution by any stretch, right? This is a multifaceted challenge that we face as a country. And we just want to say, if you implement telehealth well, you will improve access, and that's something we stand by.
On your website, it mentioned that you were creating a new model of healthcare, moving care from hospital or doctor offices into day-to-day lives of patients. We kind of touched on this a little bit, but do you think the model should be pushed on the providers first and then the patients in order for it to be successful? For example, like the EHRs, the EHRs were pushed on the physicians first to get away from the hard copy folders, the patient profiles, and now it's EHRs, and then it was pushed on the patients to get the app to have access to their EHRs, and now you're seeing it being a little more successful. Do you think that model is better if we just focus on pushing it on the healthcare providers first?
Yeah, the term pushed makes me a little nervous, but I would say I would use a different phrase, probably the same thing you're saying, which is a policy initiatives to do this that encourage providers to adopt. I agree that that's the right way, and the reason I feel that way is what I said before, which is that patients are not our customers. We help them. In ideal situations, we help them feel better and get better, but someone else pays us to do it. So having patients cheerlead for it, as I said, they should have already gotten that solved because they don't have to drive and it's easier. None of that's happened. So yeah, I think policy initiatives like high tech, which was something that came out in the Obama administration, and now, 15 years later, we are all on electronic records. That sort of thing is what we need to really drive it, I think.
I know a physician that's been practicing over 30, 40 years, and it took them so long to transition into EHRs. I think they just transitioned to EHRs maybe like 5 years ago, 4 years ago, and they were still doing hard copies. What advice would you give to those looking to implement connected health solutions in their practice or institution, but they're so like hesitant to fully embrace it?
Well, a lot of the barriers are that we used to talk about a lot of barriers that are now down. So you can get paid. That was once a barrier. You again, you should have the technology embedded in your electronic record. That was once a barrier. So really, it becomes making sure that your staff are trained to submit the right bills for the services, that the right modifiers and codes, and that this is after all that, this is I think the crux of it, which is choose the use cases best, that you don't need to touch the patient and that the patient will be happy with you for all that convenience. And don't choose the ones where they really should come in the office because you're frustrated that you can't do a lung exam or palpation or something. Bring those people in. Those people should come in.
But from your past experience in doing this for so long, are there any specific patient populations or demographics that have you seen particularly benefited more from connected health than others?
Well, yeah, we talked earlier about behavioral health. I just
Yes.
can't say I can't not answer the question without mentioning how powerful that's been, and it's such a need right now, and there's so much demand. And for people to drop out of whatever they're doing in the day and have a half-hour therapy session without leaving, it's just it's been such a lift to everyone. That's the main one. I think, as I said earlier, endocrinology, if you're caring for patients with diabetes, there's not much physical exam involved most of the time. Heart failure, I mentioned, we do a lot of heart failure management using remote monitoring nowadays. High blood pressure, sorting that out can be done remotely. So there are a number of them, and I'm sure I've only scratched the surface. So that's why I used to give these talks during the pandemic, and I always said, think about if you really need to touch that patient to make a medical decision, or either diagnostic or therapeutic on their behalf. And if you do not, then you probably can do this quite well by telehealth.
Technology is expanding really, really fast right now. Do you think that that's beneficial or not? Because what happened last month is not the same thing that's happening right now. We're already in like the next phases. It's moving
Yeah.
so fast. Is that being beneficial for someone like you that's trying to push something new and innovative? Or do you think that's a kind of a thing where you sit back and kind of move a little slower because things are moving so fast?
Oh, it's a great question. So on the one hand, I think we as forget me, but healthcare providers don't tend to move at breakneck speed. The old notion that, and we do get a lot of folks in the digital medicine space that are successful tech entrepreneurs. Sadly, a lot of them come in because they have, or a loved one has a healthcare problem, and they see how terrible our system is and say, well, we can solve that. And they come in and they use the old classic, break things and move quickly and break things. And that does not work in
Yeah.
healthcare. So there's a deliberate pace to healthcare because we're so risk averse. We don't want to hurt our patients. I don't know that we'll ever overcome that, and I'm not sure we should. So there's that. The part about your question I think is really fascinating for someone like me is, if I don't keep up, then all of a sudden I'm not a soothsayer anymore, right? So I have to keep up. On the other hand, I've seen so many trends over the last 30 years where there's always a flash in the pan. and then things died down. Right now, the flash in the pan is GPT and AI, and again, AI has enormous potential. Please don't misunderstand me, but it isn't going to take our tests for us and diagnose. I mean, it's just not, right? It's not how we're going to use it. So I don't have to move as fast to keep up with the hype. I try to parse it out. So I'm being a little bit of hopefully being a voice of reason in the midst of these hype cycles.
Do you think that we mentioned it a couple of times that like the patients are more comfortable because they don't have to leave their home; they could just sit at home. Do you think it's important to also push the initiative of that? Telemedicine is not here to replace what's already there. It's just there, like I think you mentioned earlier, to kind of boost and help and make health and healthcare better, so patients don't get too comfortable where they're like, "Oh, I don't want to go to the office anymore," when maybe they might have to. For
Yeah.
example, like a dermatologist, like they might get used to just being at home and they're like, oh, now I'll just skip the in-person one and I'll just do the telemedicine one. Do you think that's also we should be focusing on as far as our patients, that we might be getting them too comfortable to do?
Sure. Yeah. Well, on one hand, I would wish for that pendulum to swing like that, because it always swings back, because we're not there now for sure. But I think a more thoughtful answer would be, and it's careful to answer according to what I heard. We should have certain scenarios where we are replacing in-person care. If we're only adding, then that's a problem from a financial perspective, because we're just adding a whole nother burden on our health insurers and patient copays and what have you. So, but again, it's a matter of, I think, educating everyone, and I've talked about educating our providers, but our patients as well, educating them to say, if you really feel like what you need done requires a trip to the office, just say so, right? We'll be happy to take you in the office. Your call. And I kind of say that to my patients now. Do you want to come in? Again, often it's for acne, something like that. Do you want your follow-ups to be virtual or in person? And they go either way, depends on variables. But so I think the rules are, don't offer it to people when you should be seeing them in person. And if you're, as a patient, think you should be seen in person, just say you want to be seen in person. And the flip side is, try to take advantage of that efficiency, convenience for patients when really they can get stuff done without coming in, and make them happy with it.
So, as we move towards a more decentralized healthcare system, it seems like that's the way we're headed. How do you envision the blockchain technology playing a role in patient-centric care? Because since Bitcoin and crypto came about, the NFTs, blockchain technologies become Web3 is becoming a big thing, and with blockchain technology, it's better security for patient information. So, where do you see that going?
Well, my one disclaimer is I'm not an expert at the blockchain. I finally think I understand it a little bit. I've only had about 20 primers, either in people telling me or reading, but I think it's a complicated technological, to me anyway. But as I understand it, the answer to your question really is, it reverts back to something we talked about a few minutes ago, which is the idea of having interoperability and having universal. So the blockchain would allow that. The blockchain would allow your record to be in a place where only you or who you say can access it, but they can access it at any time. So I think that's as I see it anyway. Like I said, I'm not an expert, so maybe I'm thinking too narrowly, but to me, that's the main value.
You've brought up GPT multiple times during our conversation, so we got to dive into it. The use of chatbots and virtual assistants is growing in healthcare settings. How do you see this AI-driven tools enhancing the patient engagement and communication with healthcare providers? Beneficial, not beneficial? Where do you see it?
Yeah, well, I think we're not there yet. There's this phenomenon. I love the term that the GPT will hallucinate from time to time, right? So, and if you're expert enough at what you're engaging with the tool on, you'll see that right away. But if you're not, the one thing about at least GPT is it's very confident.
Yeah.
What it tells you, tells you very confidently. So if you're and our human brains are, of course, this is why a lot of politicians are successful. Our human brains are used to, if someone acts and speaks confidently, we believe them more.
Yeah.
So this tool, because it sounds so human and it's confident, but I've used it a few times for different things, and almost, I mean, I'll say all the ones I've asked to get engaged with the tool, I know enough to know when it's hallucinating. So put that on the patient side, and it's like WebMD on steroids or something. No, not really, not yet, because it may in fact give you screwy advice. So I think we got to solve that one. It's interesting. There are a couple of, we're talking earlier about not evenly distributed. There's a couple of products in the market that use chatbot front ends to do essentially engagement and disease management. And I have been not a big fan of them. These are all in the market well before GPT, because they feel stilted, right? The conversation that you have with this app about your diabetes or what have you feels to me fake.
Yeah.
It's possible that with GPT that will change, because again, it is so kind of conversational and sounds so human. I think it's important for us to realize that we have to solve this problem. One of the things that I often mention, again, when I'm out on the stump speaking, is that we don't have now we're well into a phase where we don't have enough healthcare practitioners to care for the healthcare demand that we have. And the only way to solve that, because we've lost, we can't train people. We can't train more people fast enough. The curve just doesn't work. And of course, that would just add enormous costs, which we're already struggling with in this country. So we have to use technologies that I call one-to-many and take lessons from other industries. And I always pay attention when I have a customer support question of any sort, because like I said, you get a bot first. Mm-hmm. And there are two, I see it a binary, probably oversimplifying, but two types. One type is where I literally pull my hair out because I can't get a human being. I know what, like they say, reboot. Yeah, I already did that. They say this. Yeah, okay, fine. I want to talk to a person, and you can't get one. Yeah. So we mustn't design it like that. But there are a couple, and I'll call out, it's easier to call out the successful ones than the ones that annoy you, but I'll call out Apple. They usually know within 30 to 60 seconds that I deserve a human being and get me one quickly. And that feels good, because on the front end, there probably are people that don't know to reboot the iPhone or hold the buttons down this way. And right, if you know all those things, then it becomes tedious. But if you don't, then a bot can solve problems for you. So taking it over to healthcare delivery, we have to figure out how to make that transition smooth so that people, they never feel like they want a human being and can't get one. That's a no-no. Certainly a no-no in healthcare for sure. But that they also don't feel like, you alluded to this earlier, how frustrating it can be to deal with a healthcare system. So if we can get things answered quickly and move you along and not have you be on hold rather, on the phone for 20 minutes or et cetera, then so there's an opportunity there, but we have to figure out that transition, in my opinion. I haven't seen anyone that's done a good job of it yet.
I think in healthcare, there's a comfort in hearing someone's voice. That's a real human, rather than like a bot.
Good point.
It's just whether the bot is telling me the exact same thing you were going to tell me. There's just the comfort of knowing that someone's brain.
I say that a lot of wisdom there. Yeah.
Yeah, someone's brain is thinking and telling me this rather than someone's coding something. And it's scary because now they're able to make you could be a bot right now, like that. They could make you where you're speaking exactly like who you are and look exactly like, and I think that can get a little messy and dangerous if it comes to healthcare, because what advice? Actually, I wanted to ask you about this. You recently published an article on bias in AI based models. who right now, it was an interesting article, 'cause I never really thought about that part of it. Who right now is responsible making sure that these technologies are not created with a bias? Because I never thought about someone has to be programming these AIs to function and give us the right information. Who's overlooking that? Is there anyone overlooking that right now?
There's no regulatory framework that I'm aware of. So it devolves to the individual, either data scientists that are doing the work, or oversight at the corporate level if it's a commercial activity. Yeah, it's a real challenge. The not to oversimplify it, but getting a diverse data set to train the software on is the first step, and people are doing more of that now. But there's still a ways to go for sure.
I think it's important to start pushing the initiative of having a healthcare provider part of a tech team.
Mhm.
Like going in like these like computer scientists, it's good to have a healthcare provider next to you to be able to kind of like lead you. We need to be able to provide that kind of, in a way, collaborative practice, but within every profession, not just healthcare. What
Yeah,
advice do you have for healthcare professionals and industry stakeholders to stay up to date with the latest trends? Because as we said, it's moving quick. How could they stay up to date with what you're doing, what your team or previous team is doing, what the university is doing?
sure. Well, I'll start with a big picture. So there's two or three newsletters that I are pretty religiously read. One of them is Moby, MOBI, Moby Health News. That's currently owned by HIMSS. That comes out once a day several times a week as an email, and it's some good stuff. There's the guy who founded that now has a different um, he's involved with his own thing now, and it's called E&O, outcomes and exits and outcomes, E&O. You can look him up. Brian Dolan is his name. He does a once a week, and it's a subscription service behind that if you want to be more ambitious. Um, our friends at Rock Health put out an email every Monday. There's a lot of good stuff in the Rock Health emails. So those are three that I like. Uh, of course, I have to plug my journal, and you can get an RSS feed from the journal. You can find the journal website, NPJ. That stands for, by the way, Nature Partner Journal. We won't get into that. So NPJ Digital Medicine um, is the name of the journal. If you find it, and you can easily sign up for the latest articles that come out. And we do, as I said earlier, quite a few editorials that are written in what I call plain old English, so that you don't have to be a geek to understand them.
Yeah, I like that.
So those are a few. There's the usual. You can program Google to tell you when things come out. I mean, there's lots of different ways to try to keep up. So, but it does move fast, and I confess that I don't always feel. Most of the time, I don't feel up to date. So even though I try.
And there's one other thing you left out where they can also listen to your podcast. So you do have a podcast. What is the vision behind the podcast, and what made you want to start one?
So this is a collaboration with the ATA. It's their podcast. I'm the moderator or the interviewer, playing the role you're playing today. Um, and our goal, well, it's really there's a simple goal, which is people consume content in different ways, and we all know the success of podcasting has a lot to do with the fact that when this comes out, at least the audio version, I could be riding my bike and listening to it, or doing dishes or what have you, taking a walk. So you can multitask and absorb information, which is handy compared to reading or watching a video. So there's just that, which is we wanted to be able to get our message out across different kind of platforms and the like. The twist, if I may, on the podcast is that we wanted to, and so far I think we're getting there. We just started in January, but is to interview people that will be pretty candid about some of the challenges in the field of telehealth, in a way that provokes our listeners to think about their day-to-day. I think most of our listeners are in the industry, so we want them to go back and think about how they execute their day-to-day jobs with some insights based on, again, reality checks from these various folks that I interview. So that's the goal behind it in a nutshell.
Awesome. I've listened to a couple of them and they're amazing. So keep up the great work.
Thank you.
I'll
Yeah.
leave it on this note. Is there anything that we didn't talk about that you would like to touch up on or highlight or tell the audience? Anything?
Sure. So I'll take the opportunity to tell folks how to find me. jkvedar.com is my website where pretty much everything is. The ATA podcast, you can either search my last name, Kvedar, or it's Health Virtually Uncensored. Those 3 words. It's a little bit of a long search, but if you go to Apple and you search that, you'll find it. I'm on all these social media platforms except TikTok. So you can find me on LinkedIn. Again, search my last name. There aren't many Kvedars. You can find me on Twitter, jkvedar, Instagram at jkvedar or Dr. Kvedar, DrKvedar. I have a blog on my website. You can sign up for that. So those are different ways to reach me. And my email, probably the best email for me is my work email, jkvedar@mgb.org.
Perfect. And I'll provide all the links that you mentioned in the description on all the platforms so they could just easily click on it and get in touch with you.
Appreciate it.
Dr.
Thanks for
Kvedar,
having me.
of course. Thank you so much. And I really appreciate our talk. And I can't wait to put this out for the world to see.
Yeah, we'll look forward to it. Take care.
Thank you.
Bye-bye.